This is the 8th in a series of presentations on radiography of joint disorders in veterinary patients. The intent of this presentation is to describe and provide examples of aseptic necrosis of the femoral head in the dog and cuboidal bone disease in the horse. By the end of the presentation, you should be able to describe and identify the radiographic abnormalities in and diagnose these two disorders. Let's start with aseptic necrosis of the femoral head. Aseptic necrosis affects the proximal femoral epiphysis, or the femoral head, in the dog, with secondary effects on the hip joint. The clinical signs develop approximately 4 to 10 months of age, and the patients affected are toy and small breed dogs. The process is unilateral in 85% of cases. Compromised blood supply causes necrosis of the subchondral bone, while articular cartilage continues to grow. Other terms you will see used for this process include avascular necrosis and leg calf perthes, or LCP disease. This slide lists radiographic findings. Because the underlying pathology is of necrosis, the initial radiographic findings will be of radiolucencies or lysis in the subchondral bone of the femoral epiphysis and possibly the metaphysis. This is a close-up view of the right coxfemoral joint in a small breed dog. And those radiolucencies are these kind of circular areas of lucency within the femoral head, and then there are a few circular areas of lucency within the femoral metaphysis. The femoral head will become misshapen and can even kind of collapse or fragment, and that is because when the body tries to repair the defect and remove the necrotic bone, incomplete removal of that necrotic bone and granulation tissue will interfere with healing, and that again can lead to misshapen femoral head that'll maintain some non-uniform opacity. So in this dog, this lateral portion of the femoral head is quite flattened, misshapen, and oftentimes that's because the bone kind of collapses upon itself. The secondary process of remodeling occurs in the acetabulum when there is not normal congruency between the femoral head and the acetabulum. So the acetabulum can actually become kind of shallow and flared. And then this patient ultimately can develop secondary osteoarthritis. Here's an example of a dog that has a very early lesion of aseptic necrosis of the femoral head. This is the extended limb ventrodorsal view, and this patient has presented with fairly significant pain and lameness on the right pelvic limb, and we can notice that the muscles of this right pelvic limb are quite small and atrophied compared to the left side. When looking at this right coxfemoral joint compared to the left coxfemoral joint, which is somewhat obscured by rotation, this is a close-up view of that right coxfemoral joint. Looking deep within the femoral head are these kind of oval circular radiolucencies in that subchondral bone. And these are very mild, and these lesions can be quite subtle when they are early and be missed on radiographs. But this is a very mild and early sign of aseptic necrosis of this right femoral head. This is a patient that has chronic lesion of aseptic necrosis, such that that femoral head no longer has radiolucencies with it, but has sclerosis. Some of the sclerosis goes into the femoral neck, and then that outer portion or lateral portion of the femoral head is like completely collapsed upon itself, and so it is quite misshapen. And then if you look at the acetabulum is an abnormal shape, and that coxfemoral joint is actually too wide as well. So these are kind of osteophytes as well along this kind of craniodorsal aspect of that left acetabulum. So these findings are pretty chronic. There may be some remodeling that continues. This patient looks like there may be a little bit of atrophy of that left thigh muscle as well. Here's a patient that has both an extended limb ventrodorsal view as well as a lateral view. This is an 8-month-old spayed female Yorkie presenting with left pelvic limb lameness, which is confirmed on the radiographs by the fact that there is pelvic limb atrophy. When I look at this left coxfemoral joint compared to the right coxfemoral joint, The first thing I notice is that this femoral head on the left side has kind of patchy areas of radiolucency surrounded by sclerosis. Some of that sclerosis goes down into the femoral neck. And then a portion of this femoral head is actually flattened and collapsed upon itself. Finally, that left acetabulum has a little bit of an altered shape compared to the right acetabulum. And really, these findings are not going to be very easy to identify on the lateral view. It looks like this is a right lateral view, so this is the right femur, and this is the slightly magnified and distorted left femur. So this would be the left coxfemoral joint. And again, not sure that we can see any of those abnormalities other than that maybe that joint space is a little bit wide compared to the right coxfemoral joint. So really the ventrodorsal view is going to be the view that is important. Now, there is going to be a question at some times as to whether or not the patient actually has unilateral hip dysplasia, because we said that small breed patients can get hip dysplasia, or does the patient have aseptic necrosis? So we need to be able to distinguish the two. And our primary thing is to start with wondering, is the breed at risk for aseptic necrosis? So remember that the small and toy breeds are going to be the ones that get aseptic necrosis of the femoral head, not the medium and large breed dogs, unless there was something else going on, such as some weird trauma. So that's going to be the first thing I ask. Do I have the right kind of breed? And then the most important thing is that with the aseptic necrosis, we've learned that there will be subchondral radiolucencies because of the necrosis, and we will not see those in hip dysplasia unless the hip dysplasia and arthritis is so advanced that we start to get those kind of secondary DJD changes. So looking at this patient in the center of the image of the slide, we see that this is an 11-month-old Yorkshire Terrier. So our first question was, is the breed at risk for aseptic necrosis? And the answer should be yes, because that's a toy breed, small breed. When I look at this patient, I can see that there's atrophy of the right pelvic limb relative to the left. So the patient is lame on the right side. And when I look at that right coxfemoral joint, it obviously has some abnormalities compared to the left side. The joint space is wide. There's kind of a shallow and remodeled acetabulum. But when I look closely at that femoral head and femoral neck, I can see that there are actual radiolucencies within it. So those are going to be findings of the aseptic necrosis. And then finally, my last question is, do we see it unilaterally or bilaterally? And remember that 85% of the time, the aseptic necrosis of the femoral head is a unilateral process, which is what's going on in this patient. Now let's compare that to the patient on the right. This is a 2-year-old Labrador Retriever, so a little bit older and a large breed patient. When I look at both coxfemoral joints, they are abnormal in that the acetabula are flared and shallow. Both femoral heads, but especially on the left side, have some osteophytes, and the femoral necks are thickened with some osteophytes and some sclerosis. So we don't see any subchondral radiolucencies, and this is a bilateral process. So all of those things together, the type of dog, no lucencies, and bilateral, tell me that this patient has hip dysplasia with secondary degenerative joint disease. So the second disorder that we're going to talk about is cuboidal bone disease in the horse, and this refers to incomplete ossification of the carpal and or the tarsal bones. And these bones ultimately are hypoplastic, and they actually resemble bones that are in the fetus rather than bones of a patient at full gestation. So this occurs in neonates who are often premature or dysmature, and it can be in any breed of horse. Some people consider this to be part of the osteochondrosis complex. These poorly ossified bones may collapse from weight-bearing loads, and when they collapse, that can lead to angular limb deformities and compression fractures of the affected bones. This slide lists the radiographic findings that we can see in these incompletely ossified bones. The slide also has images of a patient that has cuboidal bone disease in the middle of the slide and a patient that is a normal term 3-day-old foal. So first, let me draw your attention to the normal term foal. The carpal bones here are roughly still kind of cuboidal, so rectangular for the third, and then roughly square or cubes for the remainder of the carpal bones. And although the edges are mildly rounded, they still maintain their shape. I do see that the joint spaces seem a little bit wide, and really that's because these bones do have some further ossification that have to happen. So the width of the joint space is actually made up of the articular cartilage, predominantly from the bones that still have to ossify. And then this is the radius, and so this is the physis. So compare this normal to a patient that actually has this incomplete ossification of the cuboidal bones. So the cuboidal bones will be even rounder, they'll be smaller, and they usually have some rough edges, mildly irregular edges, with even wider appearing joint spaces. And in fact, this second carpal bone over here is hardly mineralized at all, and even that third carpal bone is not very mineralized. So this is the radius up here and the radial physis. Very small, irregular, round bones, consistent with cuboidal bone disease compared to our normal 3-day-old foal. Here is an example of a tarsus in the middle of the slide of a patient that has this incomplete ossification, compared to a patient on the right side of the slide that is our normal term 1-day-old foal. And the lateral view is going to be the best view to identify the abnormalities in the tarsus, and the dorsal palmar view, as we saw in the prior slide, is going to be the best view to identify the abnormalities in the carpus. So draw your attention first to our normal term 1-day-old foal. We have our talus and our calcaneus. We have a lot of physes, distal tibia. We have a separate center of ossification for that tuberosity. And then when we go down into our tarsal bones, our central, our third, our second, and our fourth, although they do have rounded edges, they still are kind of rectangular and cuboidal, and the joint spaces, although they are mildly wide, are not all that wide. Compare that to our patient that has incomplete ossification, particularly the central and the third tarsal bones are affected. They're very small, kind of abnormally shaped. There's a more normal shape to this fourth tarsal bone. Even the tuberosity of the calcaneus is hypoplastic. So this is a patient here that has incomplete ossification. Now, these patients, again, when they have weight-bearing loads applied, can develop compression fractures and result in angular limb deformities. Neither of the patients here have those. Here's an example of a horse that has bilateral carpal radiographs, DP radiographs. And so our left side, here's our lateral, our right side, here's our lateral side. And at this, if you look at this patient, these carpal bones are bilaterally small, round, have slightly irregular margins. Even the distal radial epiphysis is a little bit more irregular and less ossified than we would expect. And then secondary to the fact that the patient has been weight bearing on these bones that are not fully formed, there is actually lateral angulation of the metacarpus relative to the radius, and that's bilateral. So that is carpal valgus, a little bit worse on the right side. Here are orthogonal views of a slightly older horse that has incomplete ossification of the tarsal bones that has actually led to some compression fractures. So they're a little bit larger than the first horse we saw because, again, this horse is a little bit older. Notice this the third tarsal bone in the distal row here actually has a fragmentation, kind of compressed in the center. And when we look at the dorsal plantar view, the central tarsal bone medially looks pretty okay, but laterally has this kind of compressed area. Same thing with the third tarsal bone. So this patient has some compression fractures and fragmentation. Be sure to look at the textbook chapters and patients listed here so you can have some more explanation and additional examples. And you should use the index in the back of the textbook to find the item of interest.